Okay, Chapter 48, Spine Trauma. When we look at the incidence, the mortality, and the morbidity related to spine trauma, they estimate about 12,000 new cases annually. And in the grand scheme of things, spinal cord damage is an extremely rare incident. In fact, less than 1% or around 1% of all spine trauma includes cord damage. Typically, it's a 28-year-old white male that's involved in this type of accident. The range is, somewhere between 18 or 16 and 28. Cervical spine injury, of course, we know is a potential problem associated with spine trauma when you have a 22-pound bowling ball on a stick, and that 22-pound bowling ball whips back and forth. You can have cervical spine trauma. And motor vehicle collisions is by far, I think it's about 48% of all spinal cord or spine trauma comes from motor vehicle collisions. When we look at the spinal column, it's 33 bones or vertebrae, and they're isolated by regions. You have 7 cervical vertebrae, and you've got 12 thoracic, and 5 lumbar, and you've got some sacral and then coccyx that are fused together. And these vertebrae all have different shapes and sizes, but they do stack one on top of the other and create a column. The spinal column is the weight-bearing part of the spine. The vertebral arch is the posterior part of the vertebrae, and it is much smaller. It's a connection point for muscles and ligaments. It allows movements and acts as a lever for the muscles. And it's the site of interlocking articulation between multiple vertebrae. Thoracic vertebrae articulate with the ribs. The posterior vertebrae, you have the transverse process, the superior articular process, the inferior articular process, the spinous process, and the lamina. And when we look at the posterior vertebrae, we can see that these processes stick out away from the vertebral body. And these processes sometimes can be fractured or broken off. You've all had that patient that's had a broken back. Typically that's either a compression fracture of the vertebral body or one of these processes is broken off. The atlas is the very first vertebrae. It supports the head. The atlas allows you to nod, rotate left and right, and it does not have a vertebral body. So here is just a picture of the vertebral body. This area right here is the vertebral body. When these spinal when these vertebrae all stack one on top of each other, it forms a canal or a place for the spinal cord to go. Here are those different processes that are sticking out there, and certainly those processes can be snapped off or broken without causing any sort of spinal cord damage. So there's the atlas, and again the atlas is the very first vertebrae, and the atlas sits on top of the second vertebrae, which is the axis, and the axis has what's the den. This little thing right here, and when the atlas sits on top of this kind of, if you will, kind of is like a hitch, and it allows the atlas to do its pivoting and rotating. But that can be broken off as well. The dens can be broken off as well. And interestingly, prior to CT and other advanced imaging, you would just shoot an X-ray while looking straight into the mouth of the person, you'd have them open their mouth and say, ah, and they'd shoot the x-ray, and then they'd get a good view of the atlas and the axis to see if that was broken. The axis, as I've already mentioned, is the second vertebrae. It also helps support the head, and the odontoid process protrudes superiorly. Ligaments, remember LIG, B to B, so ligaments attach bone to bone. And ligaments help support the spine during flexion and extension. Ligaments lie between the lamina, and they support during lateral flexion. The vertebral foramen is between the vertebral body and the arch, and it forms a large canal the length of the spinal column, and that's where the spinal cord is housed, in that vertebral foramen. So if I were to back up and look at this, that's the vertebral foramen, and that's where the spinal cord passes through. The spinal cord is part of the brain and is part of what we call the central nervous system. The central nervous system is made up of the brain and the spinal cord. It leaves the skull through its only natural opening, the foramen magnum, which, if you remember, is Latin for big hole, and it extends through the spinal column. The conus medullaris, as well as the cauda equina, are parts of the spinal cord as well. The cauda equina comes out at about T10, thoracic 10, and it resembles, it's a big fan of nerves that then run down both legs and supply the lower part of your body from your umbilicus down. And it resembles a horse's tail, and that's where it gets its name. The central canal is surrounded by white and gray matter, just like the brain has white matter and gray matter on the outside, white matter on the inside. It's covered by 3 meninges, just like the brain is, and it is cushioned and bathed and cooled and that sort of thing by cerebrospinal fluid. So when we look at the spinal cord, the central canal, there's your gray matter on the inside, white matter on the outside, and off of the spinal cord come 2 pair of nerves for each vertebrae, 2 sensory nerves and 2 motor nerves. The ascending tracts of the spinal cord include the fasciculus gracilis and the fasciculus comitus. They conduct sensations of discrimination, so they conduct or one moment. I have to look something up here just real quick. So I'm going to stop. Okay. We were talking about the spinal cord and the ascending tracts that come out of the spinal cord, and the ascending tracts are essentially your sensory nerves. They consist of the fasciculus gracilis and the fasciculus comitus. They conduct sensations of discrimination. And what that means is they're able to tell if you're being touched in 2 different places or by 2 different things. A good example would be to take 2 fingers and touch your arm. You should be able to sense that there are 2 different areas that are being touched by 2 similar items or 2 similar things. Whereas if I used a finger and a needle, and I touched with a finger and touched close to that with a needle, you're able to tell the difference between pressure and a sharpness, and that you are in fact being touched by two different things. That's what the sensations of discrimination is. Proprioception is where your body is at, understanding, whether it's an awareness of where your body is. I don't know another way to say that, but in your environment around you, having a knowledge of perhaps whether you're standing, sitting, leaning over, has to do with balance, that sort of thing. They travel the same side of the spinal cord as the impulses will travel. They cross at the medulla, and you'll have same side deficits if there is damage to those tracks. So the left side controls the left side as it relates to sensation, and the right side controls the right side as it relates to sensation. The ascending tracts have the anterior tract, which transmits touch, pressure. The lateral tract transmits tickle, itch, pain, temperature. So these are your sensory nerves. The ascending tracts are your sensory nerves. They travel the opposite side of impulses received. You can have contralateral deficits, which is the opposite side, and they're made up of posterior tract fibers and anterior tract fibers. The descending tracts, also known as the corticospinal tracts, consist of the pyramidal tracts. They originate in the cortex and descend through the anterior and lateral funiculi. They transmit the impulses at the level of the medulla, becoming the lateral corticospinal tract. Fibers that do not cross at the medulla continue down the same side that they originated, and these anterior fibers travel on the opposite side of origination in the neck and the upper thoracic region. These descending tracts are your motor tracts. The ascending tracts are your sensory tracts. The descending tracts are your motor tracts. The corticospinal tracts transmit motor impulses from the cortex to the spinal nerves, which are then distributed to the voluntary muscles. The majority terminate at the interneurons near the gray matter of the spinal cord. Fibers responsible for fine motor function of the fingers, hands, and fine motor control are also within the corticospinal tracts. You can have ipsilateral or same-side deficits if those tracts are damaged. The corticospinal tracts lie outside the pyramidal system. They're responsible for movement and posture. They do control the sweat glands as well, which are under the neurotransmitter to stimulate those sweat glands is adrenaline. You have a lateral tract and a medial tract of the corticospinal tracts, and they cross the opposite side, travel down to a lateral funiculi, and they control muscle coordination and posture. So, a lot of big words, a lot of things that we'll probably never ever use, but to summarize it and to keep it simple, the spinal cord is part of the central nervous system. It lies in the spinal column. It is protected by the meninges and cerebral spinal fluid. And out of the spinal cord come the ascending tracts, which are your sensory tracts, and the descending tracts, which are your motor tracts. The meninges protect the entire central nervous system, so the pia mater, the arachnoid layer, and the dura mater are also surround the spinal cord, just like it surrounds the brain. The peripheral nervous system is a one-way signal pathways to and from the spinal cord and to other body tissues. Spinal nerve roots leave the spinal cord, and they distribute the autonomic information and motor signals along the organized pathways to the signal body region. The pathway collects sensory signals, and those are transmitted back to the central nervous system. The pathways are innervated by 31 pairs of spinal nerves. And a myotome, myo refers to muscle, and tome is a muscle diagram. Dermatome is a skin region spinal nerves innervate. We use a dermatome to identify where spinal cord injuries are. If the patient has no feeling from the nipples down, then the spinal cord injury is likely at thoracic 5. If they have no feeling from the umbilicus down, then the injury is likely at thoracic 10. So we can use a dermatome. It's kind of a map of the sensory nerves and motor nerves, and when we find where on the body the deficit is, we have an idea of where on the spinal cord the damage is. So here is that dermatome map. And you can see the umbilicus is at T10, nipples at T5, T4. You're looking at if they're paralyzed from the shoulders down. You're looking at C2, C3, that sort of thing. Any object in motion stays in motion in a straight line unless it's acted upon by a outside force, and that's Newton's law of motion. Speed, mass, and weight all factor into the energy diffusion, because energy can not be created nor destroyed; it just changes form. And speed is the most important piece of that whole equation. Certainly, the weight of the object is important, but how fast it's going is by far the most important. Greater the force, which is speed times mass, the greater the force, the greater the injury potential. We know that patients can have spinal cord injury and have no neurologic deficits, particularly in children. Children can have spinal cord injury without radiologic abnormalities, just because of the stretching of their spinal column can cause bruise of the cord or cord damage with no injury to the bone at all. Sometimes you're going to roll up and you've got an obvious mechanism of injury that certainly could create spinal cord trauma, to include a motor vehicle collision with significant vehicle damage, starred windshield, if the patient has been ejected from the vehicle, if they're a pedestrian who's been struck by a car, or if they've been involved in a motorcycle crash, particularly without wearing a helmet, if they fall from a height more than 3 times their own height, certain high-energy contact sport injuries like in football, and then, of course, shallow water diving, where they can suffer either a hyperflexion, hyperextension, or axial loading injury, depending on which part of the head strikes the bottom of the pool or pond or whatever they're diving into. If you're not sure about the mechanism, you can question patients, bystanders, emergency responders, but if there is no mechanism, and I strongly disagree with this slide, because what they're saying here is if there's no mechanism, then full spinal mobilization is not required. Thorough spine assessment is what needs to occur to make the decision as to whether or not you need to immobilize, not the mechanism of injury. Mechanism of injury itself, all by itself, the mechanism, even if it's a serious mechanism, should not be your reason to immobilize. Assess your patient, determine whether or not the potential exists for a spinal cord injury, and that will help you. That will be your decision to immobilize or not immobilize. The state has a protocol that we enacted this last year that I'm sure Cherry will cover in class. Some comorbid factors that certainly make spinal cord trauma more likely, or when it does occur, more severe, include medical conditions which may increase the potential for injury, may increase the potential for a motor vehicle collision, or increase the potential for a fall. Those sort of mechanisms that may cause spinal cord injury. Age, the very young, the very old, don't tolerate those type of insults to the spinal column. The old, perhaps with their brittle bone disease or brittle bones, and the young, as I mentioned, can have that spinal cord injury without any sort of radiologic abnormality. If you've got low bone density, of course, those bones can break, and if they do break, like any bone in your body, those shards may impinge upon the spinal cord and cause problems. Spinal stenosis is a narrowing of the spinal column. Much like the head, the spinal cord occupies roughly 90% of that column. And the rest is filled with cerebrospinal fluid, the meninges, those sort of things. So there's not a lot of room in there at all for swelling, just like the head. There's no room for additional fluid, there's no room for swelling, and people can have a stenotic column where it's too narrow to begin with. If they've got multiple current medical conditions, rheumatoid arthritis, Down syndrome, neck dystonia or torticollis, may make it may increase the risk of spinal column injury or congenital neck abnormalities. Your general assessment of the spine injury patient begins with seeing size up, manually control the head, control the shoulder movement and hip movement. Those sort of movements, moving the shoulders, moving the hips, are going to twist the spinal column. Open the airway with a jaw thrust without a head tilt. Apply a cervical collar after appropriately sizing. Do a detailed spine assessment to make sure or to see whether or not your patient has a potential for spinal cord injury. And you have to make sure that your patient is reliable. If they're under the influence of drugs or alcohol, then they're not a good historian, and what they tell you may or may not be reliable. So your patient has to be reliable. You've got to get a good history. You've got to do a good physical exam. And if you've done a good assessment, you've done a good exam, your patient is reliable, and they answer no to all of the questions in the spinal immobilization protocol that the state has, which is mirrored after many protocols that are all across the nation. If they answer no to all those questions, then there's no reason to immobilize them. If they answer yes, then you have to immobilize them. You also want to look for asymmetry and equal resistance, lower extremity motor function, so CMS. You want to look for circulation, motor, sensory, numbness, tingling, paralysis, step-offs, all those sort of things as you assess the spine. Your sensory exam would be having them determine the difference between soft and light touch at the distal end of each extremity, because there are certain types of spinal cord injuries where they may be able to, on one side of the body, have difficulty telling the difference between soft touch and a firm pressure, and on the other side may be unable to tell the difference between hot and cold. Those patients who don't require immobilization, who end up being immobilized because we've always done it that way, or because people don't believe in this, you don't have to immobilize everybody. The problem with unnecessary immobilization is that those boards hurt. They're painful, and if you have to lie on them prior to being cleared in an emergency department, you may lie on that board for a couple hours. And in that couple hours, some of the things that we don't see as EMS providers is the development of decubiti. I mean, they start to get pressure sores within the first 15, 20 minutes of lying on that hard board. We decrease their ability to breathe. We increase their risk of aspiration. We increase your own personal safety risk, because now you got to carry them, and you got to move them from here to there, on and off, that sort of stuff. And it makes for a difficult exam once you get them to the hospital. You know, one of the things that some people have been taught as far as an assessment to determine spine injury is to do the Babinski's. And here you can see the circular motion that you would rub something. They always used to use the handle of a reflex hammer or a pen in that direction of that dotted line, and the toes should flare out. If they don't, then there could be a potential spinal cord injury. There is an actual strength scale where you can determine whether when you have a push or pull and you're trying to determine weakness in one side over the other, there's a scale you can use for that as well. And we've already mentioned the importance of a dermatome. When assessing pediatric patients with potential spine injuries, remember that it takes less force to create an injury, and they can have that injury without any bone damage. They are more susceptible to whipping forces like the whiplash because of their large heads. And if they're under 8 years, upper cervical spinal cord injuries are more common. Again, because of that large head. And you want to go from the feet towards the head when you do your assessment. Have a caregiver close to them so that they don't move all over, especially if you're suspecting a spinal cord injury. If the pediatric patient cannot communicate and you can't get a good history, then you do have to immobilize the spine. Assessing older patients with potential spine injuries, keep in mind that osteoporosis, arthritic joints, slowing reflexes, all those things can cause falls. Falls is the #1 killer in the elderly. Their sense of pain is less. It could be from prior nerve damage, could be from diabetes, could be from just being aging. Remember that certainly things like stroke, hypoglycemia, Parkinson's disease can mimic a spinal cord injury. But if you're ever in doubt, nobody says that you can't immobilize. Even if they meet all the criteria not to, if your gut tells you that you just, based on everything you're seeing, that you feel you need to immobilize that person, then please do. The debate is whether or not that has to be on a hard board. Assessing pregnant patients with potential spinal cord injuries, particularly in the third trimester, we don't want to have them lying flat. When assessing a female patient involved in or calling, part of your assessment has to do with the potential for being pregnant, as well as if they are pregnant, is this their first pregnancy? Do they have other children? Have they received any prenatal care? Are they aware of any problems with their pregnancy? What their due date is? All those sort of questions can help you determine things like, are they in the third trimester? If so, we don't want to lie them flat because they can get hypotensive. Are they in the third trimester? If so, they've got 25% more blood volume. However, their red cells don't increase by 25%, so they're relatively anemic. And because they have more blood, they can lose a lot more before you see signs of shock. So there's all these other things that go along with pregnancy. Assessing obese patients with potential spine injury, the big problem, and I don't mean, just because we're dealing with obesity, the problem is bigger than other patients, but certainly when you're dealing with an obese patient, when you lie them flat, that's really going to decrease their ability to breathe. And the problem with that is that goes unnoticed. And I've literally seen obese patients brought in lying flat that have end-tidal CO2s through the roof because they cannot breathe. So they're not able to eliminate the end-tidal CO2. They become severely hypoxic, hypercarbic, and arrest. And it all is because they're lying flat. And nobody's paying attention to their ability to breathe. And of course, with obese patients, they may exceed the equipment weight limitations. It may be very difficult to secure them to a device. And the important thing is to restrict movement. You may not be able to put them on a board because of their size. So at least putting them on a cot that would support their weight and restricting their movement will go a long way as well. Some special needs patients with potential spinal cord injury, if they've got pre-existing paralysis, they may re-injure. It may easily be overlooked because they're already paralyzed. Handicapped patients may be driving specialized vehicles, which will make extrication difficult. And if you're dealing with a special needs patient that has a cognitive learning disability like autism, that too may be an extreme challenge to not only assess them, but to immobilize them as well. Your vital signs every 15 minutes, unless they've got a severe life threat, which may or may not be related to spinal cord injury. So that would be every 5 minutes. Splint them, recheck your pulse motor sensation, before and after splinting, and then document your findings. The pathophysiology of spine injury can be the result of direct trauma. Also, the spinal cord itself can swell, can sustain a laceration, can be completely transected or cut in half, or may be punctured as a result of a bone shard from one of the vertebrae. In all of these situations, you're going to get different presentations. We're most familiar with the complete transection of the spinal cord where the person is paralyzed from the injury down. But if the spinal cord, you can have a central cord syndrome, you can have a Brown-Séquard syndrome, you can have an anterior cord syndrome, and each one of these different syndromes will present with different signs and symptoms. Exaggerated movements, exaggerated flexion and extension of the vertebrae can cause soft tissue damage, torn ligaments, unstable step-off vertebrae, hyperflexion and hyperextension is an extreme forward movement or an extreme backward movement, and again can rupture the stabilizing tendons and ligaments, can stretch the spinal cord. Lateral bending is from side to side, and they're talking mostly there about cervical lateral bending from side to side. When we put somebody in an appropriately fitted cervical collar, we limit their ability to move by only about 52%. So they still have a 48% range of motion while in a cervical collar, with the vast majority of that percent being lateral bending from side to side. With rotational exaggerated movements, rotational where the patient spins or rotated or twists beyond the normal rotating range, and then receive a direct blow. This is most common in the lumbar and thoracic areas of the spine. Axial loading is vertical compression, and that's when compression forces squeeze the vertebrae together. It crushes one or more vertebrae and squeezes the intervertebral discs. You can do this with heavy lifting. You can do this from a fall from a significant height where you land on your feet. You can do axial loading when you start a windshield with a direct hit from the center of your head. If your forehead is the first point of contact on the windshield, you'll hyperflex, hyperextend. If the occiput is the part that impacts the windshield, then you will hyperflex. So there's rotational, that shows you what it's doing to the spine. There's diving, which shows, in this particular case, severe flexion, but it could be a combination of both axial loading and flexion. And then a hangman's fracture is distraction. Distraction occurs when the spinal cord is stretched and may or may not be severed. In a hangman's fracture, typically the cord itself is torn, completely transected by the drop and the distraction of the head staying in the noose and the weight of the body pulling and stretching that and tearing that. And with a hangman's fracture, that's an immediate death because you lose your ability to breathe. Distraction is from hanging, stretching, separation of the spinal column and the ligaments. You can also see that with mixed mechanisms. Children falling from monkey bars and getting their chin caught, and their head held, their head is held up while their body stretches. Other mechanisms of spinal cord trauma can be blast injuries, swift water, severe weather, electrocution. With electrocution and lightning strike, not only the muscle tetany or contraction of the muscles, but these patients can be thrown to the ground, thrown off a ladder, that sort of thing. You potentially might know you're dealing with a spinal cord injury because as you do your assessment and you palpate the back of the back, neck and back, you may actually feel the deformity. You may feel the step off, which would be an indication of a dislocation. The patient may complain of tenderness of the spine or pain along the spinal column as well. The primary injury is the direct insult that occurs to the spinal cord immediately following the mechanism. Not much we can do about that other than prevention. It's the secondary injury that we need to focus our efforts on. And when we have done an assessment and we know that a patient has a spinal cord injury, our focus should be on preventing secondary injury by managing things like hypoglycemia, hypoxia, hypercarbia, keeping them warm, those sort of things. Secondary injury is the result of a penetrating or direct blow. The neurologic deficit could be transient and recover. There could be perhaps no structural damage with a cord concussion, much like a brain concussion. A cord contusion, you're going to have bleeding inside that spinal column, soft tissue bruising, bleeding. That's usually the result of a more significant mechanism of injury. The capillaries within the column bleed, and again, there's not a lot of room in there for any additional things. And when blood starts to occupy that, it'll put pressure on this on one side or the other of the spinal cord and cause a ipsilateral deficit. Cord compression, that can occur when soft tissues around the cord swell. It causes ischemia to the compressed part of the spinal cord, and the damage could be permanent if circulation isn't restored to that cord. Laceration is when cut nerve bundles or nerve bundles are cut. There could also be some significant bleeding and swelling as well. There's limited recovery from something like that. If the laceration is large, then that's permanent damage. Complete cord transection, again, is what we're most fearful of and what we're most aware of, and this completely eliminates the ability to send and receive nervous impulses distal to the injury. Those injuries are permanent, they are irreparable, and result in paralysis. If the transection is above T1, you can have quadriplegia or tetraplegia. If it's below T2, you can have paraplegia. With an incomplete cord transaction, The portion damaged, uh, those nerve bundles don't work, but the undamaged part, some of those nerve bundles remain intact. Anterior cord syndrome, one of the syndromes that I talked about, is death of an anterior portion of the spinal cord. It occurs when the anterior spinal artery is disrupted. It leads to an anterior cord infarct. There should be some paralysis and then loss of pain or temperature sensation below the site. The posterior column remains intact. With central cord syndrome, it's hemorrhage in the central part of the spinal cord, leading to spinal cord necrosis. We see this particularly with whiplash injuries, and the symptoms are going to be those as with any spinal cord injury, with numbness, tingling, pain, paralysis, and those deficits may in fact be permanent. One thing to note with central cord syndrome is the paresthesia that the patient will feel. And paresthesia is the burning and prickling and tingling that you feel when you have, let's say your hand falls asleep, and then when it wakes up, that burning, tickling, prickling that you feel, that is paresthesia. With Brown-Séquard syndrome, it's a result of penetrating trauma, can also be a result of a herniated disc. One half of the spinal cord is affected, so you have a hemicordectomy. This can also be the result of spinal cord tumors, can be the result of epidural hematomas, and the signs and symptoms are the same as with any spinal cord injury, but patients may recover from this. Other cord injuries include lower lumbar regions injuries of the back, which could lead to conus medullaris syndrome or cauda equina syndrome. Remember, the spinal cord ends essentially at T10, but here they're saying that the nerve roots go as far as L2 or L3. In children, they can have spinal cord injuries without radiological abnormality, and it's called SCWRA, S-C-W-R-A. SCIWRA, SCWRA, is the acronym they use for that when talking about children. And the interesting thing here is that children's bones are so soft and pliable that oftentimes the mechanism is significant enough to cause spinal cord damage without showing any sort of bone injury. Other cord injuries include shock. From the spinal cord injury down, the blood vessels distal to the transection dilate. And this will fool you because from the injury down, the skin is pink, warm, moist, brisk capillary refill. And if the injury is high enough in the back, the patient will develop bradycardia because in addition to losing vasomotor tone, they also lose their ability to increase their heart rate. They lose sympathetic tone as well. So if your container becomes twice as big, it's half as full, and you're going to experience shock. And we call this shock, of course, neurogenic shock, because it involves dilation of the blood vessels from spinal cord injury. Other cord injuries include autonomic dysreflexia syndrome. It is a medical emergency. That's where you have intact sensory nerves distal to the spinal cord injury, transmit signals to the sympathetic nervous system, results in massive vasoconstriction and hypertension above the injury site. These patients can experience seizures, can have retinal or cerebral hemorrhage because of the high blood pressure, can cause an acute MI, because of the stress on the cardiovascular system. The patient will be pale, they may have piloerection, and piloerection are goosebumps, where the hair follicles and the sweat glands Hair stands up on the back, on the back of the neck, and the sweat glands close up. They may have a headache, sweating, visual disturbances, and not sure what they mean by a Foley catheter, whether this is something that you need to put in a patient who suffers this autonomic dysreflexia syndrome. When we talk about spinal stabilization and immobilization, the principles are to stabilize the head. The person at the head is going to call all the movements, and that's how we've always practiced it. You want to appropriately size the cervical collar early and get it on. When the person has a cervical collar on, that doesn't mean you need to let go of the head. We still need to maintain manual immobilization of the C-spine until the body is secured. Axial movements are safer than lateral movements, so you want to move in the long axis of the spine, and you can practice that when you're doing a longboard immobilization. Bring the spine into a neutral inline position as soon and as safely as possible. So if the patient's leaning forward, slumped over the steering wheel, there's nothing wrong with grabbing manual stabilization and then bringing them while lifting the head up and pulling them back, bringing them into a neutral inline position. Excuse me. Once you have them on whatever mobilization device you're going to use, scoop stretcher, longboard, vacuum mattress, there will be voids that need to be filled, and that's something that's often overlooked. As far as the head stabilization goes, is that once the head is under control, you cannot release it until the patient is completely secured. Again, the person at the head is going to direct the moves so that they're in sync and everybody moves together. The person at the head is also going to closely monitor consciousness, airway, ventilatory rate, depth, and quality. And again, they're not going to release the head until they're properly immobilized. And the head is the last thing that's immobilized. Spinal alignment refers to returning them to a natural atomic inline position, and it's safe to do that unless the patient experiences pain upon movement. Grasp the head between the hands, the fingers and thumbs are extended. You're not providing traction, you're just manually immobilizing them. If you do this from the front, there's a lot less anxiety on the patient's part, but sometimes that's not possible, and when we practice it, you're always at the head, holding manual inline immobilization. Again, don't move them if moving compromises the airway or initiates spasms in the neck or causes severe pain or neurologic deficit. SAM splint per medical direction. I'm not quite sure. Spinal immobilization per medical direction, and we have a state protocol that drives our decision as to when we should or should not immobilize. So there's measuring and applying the cervical collar. Remember, it does reduce neck flexion and extension, but it still allows for quite a bit of lateral movement from side to side. Once applied, the patient should be able to speak easily. You can use KED boards or half boards in patients who are seated. And if the condition is unsafe or the patient is unstable, they have a severe life threat, then the amount of time required to place these devices is contraindicated to use them because of how long it takes. Rapid extrication is something that we teach quite a bit, and hopefully you'll practice rapid extrication with 3 people, rapid extrication with 2 people using a Montana horse collar. We do rapid extrication when we have a life-threatening problem, when we're in a hazardous or imminently dangerous scene, when we have to move to access more critically injured patients. But the whole goal of rapid extrication is to move in a safe, more spine-stable position, maintaining control of the head, the shoulders, and hips. Immobilizing with a longboard We often forget the blanket, 1 to 2 inches of padding under the head. We often forget that. Padding the small of the back, we forget that. Putting pillow under their knees. You can use a cross-strapping method or 3 straps, or some boards have spider straps. Standing takedown or board standing is just not something that PHTLS recommends anymore. It's not a skill that they teach, but certainly I believe it may have merit. But there's just no evidence that that's how we should do it. If we arrive on scene and we've got a person who's standing and based on our assessment we believe they should be immobilized, if they've been up walking around, the idea was quickly put a board behind them and lie them flat. However, you do just as good or just as well bringing the cot behind them and having them sit on the cot, swivel around and lie back. Immobilizing pediatric patients, remember that the back of their head sticks out further than their shoulders, so you may have to pad between the long spine board and the upper back. You must maybe have to put some extra padding around the cervical triangle. In immobilizing older adults, remember that they may have some kyphosis, they may have some arthritis, and it may be very difficult to immobilize them. They may require quite a bit of extra padding, and remember that they have less sensation to pain and are more at risk of developing pressure sores after lying on a long board for several hours. So here is a picture of a PD pack with the different types of straps, and then a regular small pediatric board with straps and head blocks. And you'll practice these in the lab. Immobilizing pregnant patients, remember about supine hypertension syndrome. When you, particularly in the 3rd trimester, when you lie a pregnant woman flat, the weight of the uterus is going to put a little pressure on the inferior vena cava and decrease blood supply, decrease preload, which will decrease cardiac output, which will decrease blood pressure. So in order to prevent that, we need to, if we do board them, tip the board up on its left side at about a 15-degree angle. In immobilizing obese patients, remember, you keep them flat, they're going to have trouble breathing. You may have to place lots of blankets and pillows onto their shoulders to get their head into a neutral position. Don't put them on too small a board. If you don't have a board big enough, they're better served just having them lie on the stretcher with limited movement. Helmet removal is something that should be practiced as well in the lab. It does need to come off if it's obstructing the management of the airway or if it's loose. Otherwise, if it's not obstructing the airway, like if you don't have a full face helmet, you just have a beanie, or you have a full face helmet where it's a modular unit where you can pull the front up and out of the way, and you have access to the airway and it fits nice and tight, then there's no reason to take it out. But again, if it's obstructing your ability to manage the airway or assess the airway, or it fits real loose, it's got to come off. Spinal immobilization in the water, you need to be trained. Lifeguards are trained to do it. Swift water rescue specialists are trained to do it. Whenever dealing with a person in a water emergency, you need to approach that with a team approach rather than trying to go in yourself. Once you get the patient out of the water, keep them dry, keep them warm. Remember that hypothermia and trauma is bad. If your patient is in the water, and what we teach the lifeguards is to certainly float, sink the board beneath the patient, and then float it up underneath them, and then float the board over to the side with the patient on there, and then lift them out of the water onto the cement apron. If the person has low back pain, this could be non-traumatic. You just want to get a good thorough history. The onset, was it gradual or sudden? Was there any injury associated with it? What makes the pain better or worse? Look for swelling, warmth, and inflammation in the low back. If they have no recent history of trauma, then you don't need to immobilize them. They're more in need of things like pain relievers, muscle relaxers. Get a good set of vital signs. Make sure that you document the pain scale before and after giving any medications for pain. These could be patients with compressed discs, slipped discs, low back strain, those sort of things. Degenerative disc disease is a natural aging. As we age, our intervertebral discs degenerate and can lead to dysfunction. The outer disc layers tear slightly. The disc loses some watery pattern and may separate from the vertebrae. Now you've got a lot of tenderness, local inflammation, and pain that extends through the injured area. If the disc is if there's any instability in the disc space, that can lead to spinal cord injury as well. During restabilization, the disc hardens. They may have stenosis, or that during restabilization, the foramen or the opening in that vertebrae may become much smaller. Scoliosis is a curvature of the spine. Spondylosis is bony overgrowths along the anterior, lateral, and foramen sides of the vertebrae. It may lead to neurological dysfunction. It may compress the spinal nerves or the spinal cord. It may lead to cervical neck pain, peripheral sensory motor dysfunction, occipital head pain that radiates in the shoulders, which is Lermit's sign. Herniated intervertebral discs. The internuclear materials of the intervertebral disc protrude through the fibrous outer disc layers, so it puts a little pressure or pain on the spinal cord, and that pain is exacerbated when you move, when you flex or extend, when you sneeze or cough, or when you move your legs. Here, treatment is basically supportive, in a position of comfort, and give them something for pain. Spinal tumors is an abnormal rapid growth in the spinal foramen. It may cause permanent damage, and spinal tumors, 85% originate from metastatic cancers. Steroids for spinal cord injury are not used anymore. PHTLS does not recommend the use of steroids for spinal cord injury. Medications for neurogenic or spinal shock, you have to try to vasoconstrict the container, because in spinal cord trauma, from the injury down, the vessels fully dilate, and so you need to give a medication like either dopamine or norepinephrine to cause vasoconstriction to get the pressure up. In addition to the vasoconstriction, you're going to have to dump a lot of fluid in these folks, several liters of fluid, along with the vasopressor. Controlling the combative patient, spinal cord trauma, certainly if the patient is fighting and struggling and whatever, and disagreeing and not wanting to be on a board, not wanting to wear a cervical collar, they're better served by just having them lie quietly on a cot and document that they refused a cervical collar, they refused longboard, you told them the consequences of not being properly immobilized, yada, 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 all those good things. And it's just not wise to fight with a patient that may have a potential spinal cord injury. Be consistent and thorough in your assessments. Record initial findings, vital signs, routine physical exam, vital signs every 5 to 15 minutes, depending on severity. Identify the mechanism of injury, how the patient was found, history of whether or not they moved, and you document your own suspicion of potential spinal cord or column injury based on your assessment. Your assessment is specific to the spine. Again, document your suspicions. Tools used in immobilization. There's just such a wide variety of tools that we can use to immobilize the spine, whether they be cervical collars, all the variety of different head blocks, towels, duct tape, straps, bands, boards, short boards, long boards, KEDs, vacuum mattresses. It just goes on and on and on. And I think what is becoming more prevalent is the paramedic's ability to do a good assessment, determine that the patient doesn't need immobilized, or if they do, selecting the appropriate immobilization device. If the patient refuses care, have them sign a form as well, and the form should include your assessment of the patient, your concern for potential spinal cord or column injury, and that the patient was alert and oriented, that they were informed of the consequences of not receiving help. You have a witness sign as well, and also document that the patient was not abandoned. You told them to, if they had any further problems, to call 911, to show up to the hospital, or go to their family practice physician. If the patient refuses spine assessment, document that thoroughly as well, and have the patient sign the refusal forms. All right. So with that, I think probably the big push with spinal cord trauma is that it's extremely rare. When it does occur, there'll be symptoms, and you'll know it. There will always be that patient that may present atypically and not have the classic symptoms, and it's going to rely on your thorough assessment as well as your gut instinct as to whether or not you feel the need to immobilize them. The big question of late is, what do I use to immobilize them with? And that's going to depend, primarily on what you have available to you, what your local practice is. But do remember, if you put them on a hard board, that it is not without risk of aspiration, risk of decreasing their ability to breathe, increasing pain, increasing movement because they hurt, development of pressure sores later, and we just have to get away from using hard, long spine boards. I foresee scoop stretchers becoming more and more valuable, where you just scoop the patient up, put them on your cot, and then remove the scoop stretcher. TNCC, the Trauma Nurse Core Course, one of their skill stations is how to get the patient off a board. So when EMS brings them into the ED, these ED nurses, after that quick assessment, much like we saw the physicians do years ago, quick assessment and get them off the board. All right, so if you have any questions, you know how to get a hold of me, and I'll talk to you soon.